Good morning, everyone. Thanks so much for joining us again this week. We're really excited to welcome our guest, Elisabeth Burak, with the Georgetown Center for Children and Families. I'm going to share a little bit more about her in a moment, but one of the other things we want to do now that state budget season has officially kicked off is give folks a quick update on what's happening at the State House each week. So, as many of you probably saw, Governor DeWine introduced his proposal for the state spending plan on Monday. We were very grateful to see that most of his address did, in fact, focus on children. So, very grateful to see that that is top of mind for the administration. House hearings started the very next day. So, we saw the Nonpartisan Legislative Service Commission come in. We saw the Office of Budget and Management, which is run by Governor DeWine's administration, come in and share their outlook on the revenue forecasting for the current and upcoming fiscal years. And then Wednesday, our team also went and saw the Ohio Department of Medicaid, which is very relevant to today's conversation, Ohio Department of Job and Family Services, and Ohio Department of Children and Youth. So just a couple quick highlights from the hearings this week, and we will be sure to plug everybody in as soon as there's an opportunity for public testimony announced. We are keeping our eyes on all the committee notices, and we'll be sure to engage this group and blast it out to everybody when there's an opportunity to engage in public testimony. Couple highlights regarding Medicaid. We were grateful that some of our legislators brought up the topic of the continuous coverage for the birth to three population that has been passed in the last spending plan, but actually has not been implemented yet by our state Department of Medicaid. So we are hoping to see some more clarity now that there have been a lot of legislative questions around what the timeline looks for that work. Department of Children and Youth covered their top three goals of reducing infant mortality, improving kindergarten readiness, and keeping kids out of the welfare system. So we heard from Director Wente about their expanded investments into community-led programs to combat infant mortality, about their work to ensure that publicly funded childcare is available for folks up to 200% of the federal poverty level. That's through a combination of expansion of the program in law, as well as of the additional child care vouchers that the governor started last year. So we'll learn more about what that breakdown looks like in the coming weeks, but those are the highlights from this week. Without further ado, I want to introduce Elisabeth Wright Burak, who is with Georgetown University McCourt School of Public Policy's Center for Children and Families. She is a senior fellow there with over 2 decades of experience in federal and state policies that support low-income children and families. She currently leads CCF projects on Medicaid's role in supporting early childhood development, which is prenatal to age 6, and maternal health. Elisabeth is going to talk about Medicaid more broadly, but we've also been highlighting, they just published a really great report specific to rural Medicaid experiences, and we've been sharing that data across our network. So I will let Elisabeth share a little bit more. I won't go into all of the background on your amazing resume of education and experience, but I want to make sure you get a lot of time to talk about the heart of your work. So I'll welcome Elisabeth to share her screen when she's ready, and she'll dive right in. Thanks, Elisabeth.
Thank you so much, Brittany. And I will say there is no need to read that bio in full. I was at the Head Start conference last week, and actually it was right when everyone's funding was being frozen. So I felt terrible talking even about Medicaid at that point. But they read my entire bio, and I was just like, well, I got to shorten that. It's really not unnecessary. Thank you so much, Brittany, and for the groundwork for having me. It is a really interesting time in federal policy right now. And I imagine you all have lots of questions that I may or may not be able to answer. So I'm going to try to be quick, but I do want to make sure we just give an overview of kind of where things are and what kinds of conversations we're seeing around Medicaid at the federal level, because I do think it's particularly pertinent, not only given Medicaid's reach in rural areas, which I'll give a little bit about and we can pass along, but also, of course, as you all well know, the really critical importance of Medicaid to healthy pregnancies, healthy postpartum, and young children. So I will just start. Hopefully, oh, it's going to let me. Okay, there it goes. Just a reminder to you all, because I don't know that it's always known. I mean, we know that uninsured children, uninsured adults, we have been in recent years at the lowest level on record in terms of uninsurance, thanks largely to Medicaid. But something that's also beginning to emerge in some research by economists is the long-term effects of Medicaid. that not only are kids who have had exposure to Medicaid as children in the long term healthier, they're also more likely to have really good educational outcomes, high school or college completion, and earnings even as they get older. In fact, one of the more recent studies actually showed that the baby who was in the womb of the pregnant woman who had Medicaid decades ago, their grandchildren benefit from some of these economic and educational outcomes as well. So it's really quite fascinating. And when you have a program that's nearly 60 years old, you can start to see those investments and how they play out. So first, I just want to talk about just the progress you all have made, and a lot of states have made. And Brittany mentioned the multi-year continuous eligibility, so making sure children don't get disenrolled for red tape reasons. Um, as of this past January, 9 states have been approved to do either 0 to 6 or 0 to 3 continuous eligibility. So we certainly know, I know you all are eager to get Ohio to get their waiver in, and we're hopeful that would get approved. But we have now 9 states to look to. And I can tell you that this is continuing to be debated in state houses. I've been testified to the Montana House committees recently. It's coming up in Virginia and other places. So I think it's still a really important topic, and it shows the commitment to children really remains, especially after all the what was a tumultuous unwinding period, right? Um, so I mentioned too, I think it's worth mentioning the importance of expansion, which in Ohio, of course, you've had. And expansion in particular has been really, really important for improving infant mortality and maternal mortality outcomes. And part of that is because it makes sure that pregnant women have coverage before, during, and after pregnancy. And you can see in Ohio, and this is also true nationally, that the levels of uninsured women of childbearing age are much lower in states that have expanded Medicaid. Of course, there are always disparities we need to do a better job at, but in general, it's not Medicaid postpartum is really great, but the expansion itself has been an incredible tool to combat uninsurance for women and help them get the care they need before they get pregnant. And of course, again, you all probably know it, about 40% nationally and 40% in Ohio, the births are paid for by Medicaid. It is a major payer in the health and the maternity care systems. And I'll say, as these conversations about cuts are having at the federal level, the role of rural hospitals and access to birthing and OB care has been prominent with a lot of the leaders in Congress. So that reach really matters. Brittany mentioned the rural report we put out recently, and we really worked with researchers at the University of North Carolina to designate different counties across the country as either metro areas or small town/rural areas. I will say that's not a perfect designation. There are probably some areas that feel rural that because they have a relatively large city in them might feel different. So this is probably even an undercount. But it regardless of how conservative the estimates were, it showed the reach of Medicaid in rural areas. And we know in Ohio in particular, we were struck that 30% of the children in rural areas and small towns get Medicaid or CHIP, and that's the 8th highest number in the country. And again, we really still think that's an undercount. It's probably a lot more based on the other data we've seen. But you can go, we have a report on our website where you can go and embed this map. You can click on your county. You can really find out sort of what that Medicaid percentage coverage, regardless of its metro or rural area. But the reason we really wanted to highlight rural areas in particular is because it's often assumed that this is, Medicaid covers folks only in large cities and metro areas. That's just not the case. And particularly given the challenges we know are already happening with healthcare in rural America, that's important to point out. Okay, so before I talk about what the threats are, I wanted to make sure everybody here understands how Medicaid is financed right now, because in its nearly 60-year history, that's sort of been the piece, right? This is mandatory federal funding. It's not like a lot of discretionary programs at the federal level where you have to go back and ask for them every year. That's a good thing. And it's open-ended funding. So as I'll show in some slides, the state puts in a particular amount of money to pay for anyone who's eligible and enrolled in Medicaid. The federal government pays its particular match. And I think it's 67, I know what happened in the last slide, 65 for Ohio. regardless of what happens, that match is there. When there's a recession, that federal partner is theirs. As costs go up, the match goes up, whether it's a new drug that helps treat HIV, or a new drug that helps with hepatitis. Those things, the cost can be, especially in healthcare, particularly varied. And so the federal partner is always there to help the state meet the needs of those populations. So here are, you'll see the regular FMAP, Federal Medical Assistance Percentage is what the federal match is officially called. And on the left-hand side, that's Ohio's regular match. In every state, the Medicaid expansion population has a 90% match. That's because of the way the Affordable Care Act did it to ensure that states had the ability to really take on the expansion population. And then there are some other matches that come in as well. But I bring these up to show because one of the proposals on the table is to lower those expansion matches or lower the matches for some states. And that's a lot of money if when you start to look at the volume and the magnitude of the proposals on the table. So in Congress right now, you've probably heard about different debates, both in the House and the Senate. They're really trying to figure out where they can make big cuts. And I'll just say there's been lots of lists of cuts released. And in every list, Medicaid is the number one target. They want to cut anywhere from 200 billion to 2.3 trillion, in part to pay for some of the tax cuts for wealthy folks they want to pass through. And I say that because the point, anytime we're hearing of these proposals to cut Medicaid, there might be philosophically some good or bad things, but the bottom line is they're trying to cut money. And the result of big cuts at the federal level, even though they might not seem there, it's hard to kind of translate what that means when there are big numbers being thrown around. What it means for states is a big cost shift. It means taking all that money that's not coming into the state, and the state has to decide how to make up for those costs. So this slide sort of shows on the left-hand side in the current Medicaid funding system, anytime the state spending goes up, the match goes up with it. And on the right-hand side, if you have a cap, that doesn't happen, and the state's responsible for any other caps. And what happens is the state then has to decide, we can't possibly make up for these millions and millions of dollars coming into our state. Where are we going to cut? What optional services are we going to cut? What population eligibility levels should be cut? And that puts an incredibly difficult decision on state lawmakers, right? It's the federal government passing the really hard decisions, frankly, onto the governors and legislatures and states. And I think one of the reasons we talk about this with our state friends like you is to let you all know so you can remind them that's a terrible position to put states in, right? It doesn't seem like a big problem to do that in Congress, but to get it to the state level, that makes really hard decisions. That, I should say, with the magnitude of any of the cuts we're talking about, means potentially denying hundreds of thousands of people care, right? You might have to get rid of the expansion. You might have to cut certain services. And what's particularly frustrating to me is the incredible progress that states like Ohio have made in maternal health and Medicaid and early childhood health. There's been incredible attention on that. And I hate to say it, but I think those are a small portion of what's at risk if the kinds of cuts that Congress is coming up or is contemplating come into play. There's just to paint a different picture about the state risk here. We looked at the state budgets, but we pulled them out between state and federal funding that's flowing into state budgets. And so here's Ohio's, right? You see Medicaid is about a quarter, but of course, K-12 education's more than a third. That's the big state spender, right? But when you go to looking and unpacking the federal funds, Medicaid is at 70% of the federal money going into Ohio. So you can imagine that is even small cuts. That's a lot for the state to try to take on when you're getting 65 or what was it, 65% of the payment from the feds. So this is really the graph that we always want to bring because it really speaks to where states might have to decisions. And for us, it's not just the risk of cutting Medicaid, and that's a big risk, but it's also the risk of cutting those other state-funded programs that families need, right? Whether it's education, whether it's childcare, other things. And that is where even more of this risk comes down. So we are talking to groups like you all and working with really smart, talented folks like Groundwork Ohio and others in states to really ramp up education about what Medicaid does. And I think It's not an understatement to say that most people have forgotten the role that Medicaid in particular plays for kids, plays for pregnant women, pays for seniors in nursing homes. And so it's a good time to remind people how important the program is to all the work that many of you are doing and for the families you're serving. Um, and what kind of risk that puts on the state lawmakers to have to make. And using coalitions like this to sort of have these conversations and figure out who's got good relationships that can get to the delegation or make phone calls, right? I think today is actually a national day of action to call about these cuts. And I will say, it seems really overwhelming right now. There's a lot to be overwhelmed by, but we have some glimmers of opportunity. So one is last week's freeze of federal funding, which I know particularly hit Head Starts, but it also shut down a number of Medicaid systems around the states. That was in some ways a really good gift because it gave a lot of attention on the kinds of things that Medicaid does for families, and Congress was overwhelmed by calls and feedback. And as a result, a little bit after that, we also saw President Trump for the first time. He didn't mention Medicaid in his entire campaign. They only mentioned protecting Social Security and Medicare, which means Medicaid is the target. Last week, he actually said he included Medicaid in the list of programs he wants to keep. He wants to love and cherish Medicaid. And while we certainly wouldn't trust just the phrase like that, it shows the power of the kind of work that Groundwork and other folks in states and others have done to really raise attention to the magnitude of the cuts that Congress is considering and has considered many times before. And recent polling also shows that no one wants these cuts, not a one, not, well, a very few. I shouldn't over exaggerate. So I think that's an also important piece to the puzzle. So we are here to try to help you as much as we can. We have an entire resource page dedicated to this. We're constantly trying to release information that helps you all spread the word. And we increasingly are having more pieces we're putting out. We're putting out a piece on Medicaid and child welfare next week and other sort of pieces that tell the story of Medicaid's important role for kids and families. And we want to help you and your partners like Groundwork do that. So I'm going to share these slides with the folks at Groundwork. So I'll stop there and just see if anyone has questions or anything I can clarify.
Thank you so much, Elizabeth. We do already have one question in the chat from Shelley Hill. You didn't reference this in real time, did you? And I missed it.
I
I don't
didn't
think you did.
know.
Okay.
No, I
I
was
was like, I don't
in
think we've talked
slides.
about this yet. Shelley mentioned she read the rural report and loved it. But she wondered whether Georgetown has any studies or reports existing or in the works about WIC enrollment and outcomes, which is also a really big topic here in Ohio. We have significant under enrollment, and we're one of the few states that is not entirely up with the online capabilities. So any reference points there would be
So
great.
So our center is mainly focused on health coverage, but I'm going to go back and ask some of our partners that might be doing that because it's a really important program, of course, and resource. And increasingly is another place where we've seen Medicaid and WIC start to do more to boost WIC enrollment. So let me get back to you and see what some of our partners that do WIC are working on, because that's a great point.
Thank you so
So
much. I'll also, while folks are thinking about other questions, and please feel free to come off mute, I did want to mention, so the Ohio House Finance Committee has not yet heard our Medicaid. Um, I'm sorry, they did hear Medicaid this week. So many committees. In any event, a different committee had members that were commenting on the our current request for Medicaid dollars being $6 billion over what it was last General Assembly. And so would love any thoughts you have. I took loud and clear your point that if there are cuts at the federal level, that means states are meeting the gap. Anything you might be seeing in other states about how we can convince folks in the legislature to be supportive of that work?
yeah, and especially when you've got spending plans that are important. I mean, I would just make sure that they're aware of where Congress is. I mean, there's a feeling in some states that that's a risk because you don't want to keep what's going on at the state level. But if they're not aware, I bet they were aware last week when these freezes started coming. So I think just say, look, there's a really live conversation happening at the federal level, and we can't do our jobs, and you can't do your job with this even extra spending if the federal government's not going to be a strong partner that it has been for 60 years almost, right? So I just always remind people, just don't assume everybody remembers that what Medicaid's reach is. A lot of lawmakers do, but don't assume, remind them of, and I think one of the reasons we did the rural report is we understand that that's not well understood. And I will say this, the House Energy and Commerce Chairman um, last week, as they were kind of they've gotten a lot of pushback from moderate Republicans in Congress about some of these big cuts. And because they're hearing from folks like you all are legislators in states, and the Republican chairman last week said he's getting a lot of pressure because of rural hospitals. He doesn't want to mess up rural hospitals. And that is, I think, a really, really important point. And it's not just, we know it's not just rural hospitals, it's all the healthcare providers we're trying to keep in rural areas. And so I think leading into that is also really important. This is an economic issue as much as it is a healthcare issue and services to families. And I think helping everyone understand that is also really important. I always tell people, don't assume people understand Medicaid the way you do, because they just don't. We're still educating between the difference between Medicare and Medicaid in some situations, right?
Absolutely. And we have so many freshmen that, it's just constant with term limits here
Yep,
in
it's
Ohio. We have a
constant.
lot of re-education. And I see some folks in the list today who can tell that story that you're painting about the side of healthcare access and connecting folks to services. So I'm sure those folks are hearing you loud and clear as well. Let me
Well,
see.
and I'll just say to that point, I am not here to be a Medicaid apologist or suggest that Medicaid is a perfect program, right? That's why you all have been doing the work to get different kinds of care and coverage, but gutting the program is not going to make that stuff better, right? And I think that's part of the conversation.
Absolutely. Anybody want to hop off mute? Don't be shy. There are 70 some folks on here. I know you've got thoughts.
And if I went really fast through those slides too. So if you want to hear about specific proposals, I didn't want to get into too much, but I'm happy to if you have questions.
Thank you. And I'm going to throw, for folks who do have a Medicaid story to tell, I'm going to throw our advocacy day link in the chat too. It's free to attend on March 12th, and we'd love for folks to register and come, raise your voice on this topic. Hi, Leanne.
Hi, I've been listening. I was gonna selfishly ask questions if others didn't have some, and not
Please
selfishly. I
do.
think it'll benefit everybody, but we were just listening to the director testify yesterday to the Finance Committee, and there are certainly commitments, including the prenatal to three multi-year or birth to three multi-year continuous coverage for kids that we're trying to get movement on. And there's policymakers were indicating lots of other ideas around potential waivers for different things and groups. And it sort of fell into a bucket of what my takeaway was, a bucket of, if we're able to, regardless of whether it was in law or not, or this thing that may change spending.
Right.
All that to say is, can you talk about any knowledge or any insight about, even if we get things moving at the state level, what is the likelihood of or in timeline for passage of or approval of any of these waivers with new leadership?
Yeah. That's a great question, Leanne. Who aren't you supposed to be still on maternity leave or no?
Nah, I came back this
I'm
week.
so impressed.
You're stuck
No,
with me.
no. I just want you to get the parental leave. Welcome
No,
back.
I did. Thank you. My
Commitment,
baby's
commitment at
safely
the
home with my
Capitol.
husband. Safely home with my husband. And protesting bottles, by the way. She'd rather
Oh,
have the real thing.
that's always fun. So good question. And I cannot pretend to be someone who understands what the administration is going to be doing. They're probably, look, you all have a work requirement waiver in. If Congress doesn't mandate that for the expansion population, which is a real possibility, and frankly would be one of the least bad things that they do, then we know it's going to happen through waivers, just like it did in the last Trump administration. And I think my guess is that they would start with those, right? They would start with the things that are lining up with some of their priorities, changing the funding structure of Medicaid, trying to do that at the state level, which we can talk about, and we're happy to help you if that kind of stuff comes up. It's hard for me to. I don't really know what they would do about multi-year. It's entirely possible they could rescind all the approvals that have happened in the last few years if they don't like. But that one seems like not a good idea politically, right? I mean, we've really had traction across the aisle in a lot of states, or they just have other priorities, so it's hard to know. I would certainly hope coming out of Ohio, especially if you have other things, may or good or bad, that are coming in the neighborhood, it would be something to keep in the mix. But I don't. That's as much as I can pontificate in my crystal ball, Lynette.
Thank you. I recognize I asked you a question that I knew you were going to reach into your crystal ball. Like,
Yeah, I know.
there's a lot of unknown.
I know. I believe me, we wish we knew too.
My
I see.
follow-up, oh, go ahead. Someone else is, and
Oh, I just saw Robert Hakes pop up and I thought we could call on him in class this morning. Hi, Robert.
Thanks, guys. I appreciate opportunity to ask a question. And Brittany and Lillian, thanks for hosting this as always. And Elizabeth, thanks for your time. So I had a question. So the House Medicaid Committee had a hearing this week and had an interesting testimony provided from a think tank. And a lot of it was trying to provide proposals to reduce Medicaid spending and reduce the amount of people on Medicaid rolls. Part of that and some of the numbers they put forward was, I think, supporting worker requirements. And one was a number where they were highlighting, in the Group 8 population, that expansion population, that about 80%, that some studies that have been done found about 80% of the population in that group were non-disabled, had the ability to work, basically, and weren't working. Basically found that a vast majority of that population could work but weren't working, and basically highlighting it as taking advantage of the program. I'm interested. I have my own thoughts, but I try to be as unbiased as possible as I can, especially when we're dealing with the legislature who's going to hear that, and that's pretty impactful for them. But I'm interested from your perspective, what you've seen in your research, especially with that specific population. And for us who are trying to support Medicaid program, what can we kind of bolster ourselves with to fight arguments or narratives?
Well, I'm certainly going to get our data team on this to get you some information from where we said. I in the past we've done, I can't remember if we did one for Ohio, but I'll try to look. We've done analyses of the expansion population in states to look at who's working, and the majority are working, at least part-time, and or caregivers, or do have a disability. And I want to know how they're defining disability, because that's a moving target depending on the program and what we're talking about. So I'd love to take a look at that testimony and work with my colleagues to see what we can put back for that. The thing about work requirements that we've seen, and when it's been implemented, even in places that fully did, which Arkansas is the only place it was fully implemented, it just depressed enrollment, and most people who didn't get the coverage were working. So I think that they're trying to change things up a little bit in the proposals, like not requiring regular checks or regular paperwork to try to get around that. So we'll see. They're definitely going to have to be creative in new proposals, at least legally. So I don't, we'll see. But that doesn't reflect what we've seen. So I'm going to go back and find out what we could pull for Ohio, and we'll certainly get back to you.
Awesome. Thanks. And I know we're at 10. So the only other thing I'll throw out is that if you are looking into it, the other thing that they highlighted was, I'd have to go back to check the exact number, but they claimed that 42% of Medicaid cases or claims in Ohio were fraud. So that was another number that jumped out as fairly surprising to me. I'm not going to act like I'm a Medicaid expert, but I've worked in and around it for a couple of years. So that was a little shocking to me. So
that sounds high, and I'd want to know exactly what they're talking about, since historically most fraud in Medicaid is actually small based on the program, but also providers and not beneficiaries. And I think the rhetoric is designed to try to make it look like it's those who are enrolled. So
there was some follow-up within the committee. I think it was maybe there will be additional, like a memo or something that comes through, because I feel like it was a little bit murky in the presentation.
Yeah, we'd love to see that. Thanks for bringing that up. Yeah.
I know we're closing out. I did want to mention, and thank you, Robert. Natalie Petrosky says, also of interest, Director Corcoran said in House Finance yesterday, they are seeking to implement a trigger law that would end Medicaid coverage for the expansion population if federal funding match falls below 90%. So lots of different angles to the threat of coverage. Lynn, you had mentioned you had a follow-up. Did you want to squeeze one more in?
I'm okay. There was there's been some issues around providers getting timely payments over the past couple of years, and I just there was a statement made that it often takes 5 to 7 years for IT updates or implementation. And I just thought you could just, I don't know what that means. Like, I don't know how long it takes, but as you've seen other states, does that
I,
seem unusual to you?
it does.
Okay.
But I come from a state where we were actually the fastest payers in Arkansas, so I think it varies by state. It'd be interesting to kind of look behind that. But that speaks to a different issue too, which is, just the freeze last week has delayed a lot of payments, and community health centers in Virginia are literally closing right now because of it. So I think, just those mechanisms are important, delayed or not, in terms of keeping the lights on. A lot of these programs and centers don't operate with huge margins, right? But that's a good
Also,
question.
just to hop back in real quick, Arkansas was the state they highlighted as the 80% number for those in the Group A population. So,
That's categorically wrong. I'm going to go find that.
yeah,
Okay.
just wanted to throw that out there.
Elizabeth's going to find the receipts.
Well, you're the
Yeah,
Arkansas
no.
expert.
We know I've been gone for a while now, so I gotta call in reinforcements. I will just say one more thing about the expansion, which is that, well, I lost my one more thing about the expansion, so never mind. Don't
Well,
worry about the work requirements to get you information.
we'll hyperlink your slides, Elizabeth, and if
Yeah,
there's anything else you want to send along, we'll wait a little bit too, so that if there's any additional resources you want to
great.
tap in, feel free to add those, and we'll send the recording out as well. Thanks so much for spending your morning with us. We really appreciate it. We love working with you, and we'll talk to you soon.
Thank you all.
Take care, everybody.